Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my friend and colleague, Dr. Christine Kay, Director of Clinical Research and Director of Retinal Genetics at Vitrio Retinal Associates in Gainesville, Florida. Welcome, Christine.
Thank you, Arshad. Thank you for having me.
As the world-renowned expert on inherited retinal diseases, I'm really excited to have you here today, because in this episode, we'll be discussing emerging therapies for rare retinal diseases and recent advancements in the treatment of those diseases. But Christine, before we get started, usually I want to have you tell us a little bit about yourself so the audience can know you better. You know, usually they see you on the podium in publication, but they don't really get to know who you are. So tell us a little bit about how did you end up doing what you do, being a retina specialist?
Sure. Well, the easiest, quickest beginning of the story is that my dad's an ophthalmologist. He recently retired. He's a general ophthalmologist. So I grew up the daughter of an ophthalmologist and watched him do a blepharoplasty, and remember kind of like getting sick and like, oh my God, this is so bloody. When I was like 11 years old. But anyway, went to med school, still looked at all the fields, liked everything, but I really loved ophthalmology. Kind of makes sense. And I liked the idea of surgery and clinic. And then within ophthalmology, I just fell in love with retina. So I really enjoyed neuroscience. I did that as my undergraduate degree. And I fell in love with retina because there's a lot of brain involved in the retina and a lot of and then I love surgery. So I ended up pursuing retina, and then specifically I did my fellowship at University of Iowa, and Ed Stone there is a retinal geneticist. So that's where I actually, as a fellow, fell in love with inherited retinal disease and was awarded a Foundation Fighting Blindness Career Development Award, which kind of launched my career early on as a clinical scientist in AAV gene therapy, and interested in developing gene therapies for inherited retinal diseases. And many, many years now later, I'm now in a private practice setting as the director of a clinical research group at Vitrio Retinal Associates, like you said, in Gainesville, Florida. I'm proud of the IRD clinic that we have, and I'm proud of our clinical trial practice, and I love what I do. So, but that's the story.
Very impressive. I'm always impressed with your energy and your really passion to move the field forward, which is excellent. So now we know how you ended up doing what you do. Tell us what you like to do outside work. What's your favorite hobby?
Okay. This may be surprising, but we're a horse family. So we have horses.
Wow.
We run a farm. We also have goats, and we just had a baby goat and a set of twin baby goats. So I'm a farmer on my off time, and the hobby of the equestrian, I'm not good. I just literally ride flat work, and I'm trying to learn dressage here later in life, and get lessons a couple times a week. So that's my sort of midlife crisis. Let's see if I can learn some dressage. I grew up with horses, but I'm trying to actually get a little bit better. And my kids ride, so I mostly just tag along with them and watch them go to little shows and jump cross rails. So we're a horse family.
Oh, wow. Who knew, right? So that's great that, wow, you're riding horses and taking care of goats. Is there really, no, I mean, I always thought that I would like to live in a farm, but
Yeah.
it's hard to find time, right? Because we are so busy, but I'm glad you're able to take some lessons and spend some time with the family doing what you like to do. Okay, so let's go to topic at hand. You know, there's so much going on, right? As a non-IRD specialist, I get confused sometimes. There's so many programs in Stargardt. There's so many programs in retinitis pigmentosa. There is, gene therapy. There is optogenetics. There's so much going on. So let's try to break them down a little bit. And of course, nobody better than you to kind of tell us a little bit about these programs. So let's cover first few programs here. We have optogenetics with MCO-010 and RTX-015. And then you have the OCU 400, another program targeting RP. So can you tell us a little bit about those programs?
Yeah, and I think great question there. Big picture, we're going to talk about the gene agnostic programs right now. So these are programs that are targeting patients typically with low vision, with RP or various forms of retinal degeneration, where it doesn't matter what the genotype is. And so that's why it's important to kind of differentiate that when we're going to maybe talk later a little bit about gene-specific programs. So RTX-15 was I think the first one you mentioned. That's an investigational product, and it is an optogenetic program. It specifically targets retinal ganglion cells. So one way to differentiate these optogenetics programs is what the target is for the transduction of the AAV. It is currently being evaluated in a phase 1 clinical trial for patients with RP and choroideremia. So that's the two targets for the phase 1. The trial is targeting patients with low vision. The phase 1 is open label. It's not randomized. It's a dose escalation study. Approximately 18 adults with RP or choroideremia will be enrolled in up to 4 dose cohorts of this RTX-15. The enrolled patients, importantly, receive an intravitreal single injection. Another big differentiating feature, is it an intravitreal program or a subretinal program? So this is an intravitreal single treatment of the RTX-15 in the study eye, and they, of course, follow these for 5 years since these are gene therapy studies. The primary endpoint is safety, of course, but the secondary efficacy endpoints that are important to mention are BCVA, low luminance VA. You'll hear a lot about in the IRD world. We're very interested in low luminance VA, full field stimulus testing or FST, and the multi-luminance mobility test at 12 months. And so that's a phase 1 trial that's ongoing, and it's an exciting optogenetics program for, again, it doesn't matter what the mutation is. The other program is the MCO-10 optogenetics program, and this is another gene agnostic vision restoring optogenetic program. This you can differentiate because it targets bipolar cells, and it does so in a similar way. It's an intravitreal single injection, patients with low vision due to RP. So that's important because it can, in fact, the whole purpose of this is to rescue and bring vision back, as opposed to some of the other therapies where we want to treat really early. The whole point of optogenetics is to be able to restore vision by targeting bipolar cells. In this case, with the AAV2 delivering something called multi-characteristic opsin, or MCO, and that's a transgene that allows a bipolar cell to think that it's a photoreceptor cell and start being able to see light. This is a one-time intravitreal injection to be able to deliver a highly photosensitive opsin protein and restore, hopefully, vision in patients with permanent visual loss otherwise. So this is a Restore phase 2b/3 multi-center trial that is completed. Randomized controlled clinical trial demonstrated statistically significant vision improvements of 0.3 logmar, which will be equivalent, for those of us who think in lines rather than logmar, would be equivalent to 3-line gain on an ETDRS chart. And these patients are lower vision, so they're not necessarily seeing it on an ETDRS chart, so we're measuring logmar visual acuity. Durable efficacy sustained over a 2.5-year period in patients with RP. A rolling biologic license application has been submitted to the FDA in June 2025. So that's exciting data for Optogenetics for RP. And then lastly,
before we move on, I have a quick question.
Sure.
So why target ganglion cell versus bipolar? Is there a difference
There is a difference,
genetics, or it does not matter because you're just trying to make any cells act like photoreceptors?
So some are easier to target. There are reasons why a company or a therapy might target a ganglion cell versus a bipolar. One thing that I've learned in the field is that the bipolar cell has the capacity, because of the way the the matrix of the bipolar cells and how they're situated anatomically within the macula, have the capacity, theoretically, of a visual acuity improvement to the 20/60, 20/70 range. And so that is a great target if you can effectively with your AAV, and everything needs to work with the preclinical data to move in to the human clinical trials. But if you can target a bipolar cell, it does have that potential advantage of that visual acuity improvement. Now, the ganglion cells might be closer, especially with an intravitreal injection, and are maybe more amenable just to the logistics mechanically of an intravitreal injection. So there's pluses and minuses and different reasons, and then we have to have rescue and preclinical data or good preclinical efficacy for a program to move into humans with a given product.
Wow, that's very important information. Thanks for sharing that. Okay, so now let's go to so optogenetic seems like very exciting, but reserved for it's gene agnostic. It's low vision patients trying to make them see by making cells that are still functional act like photoreceptors. So that's very clear. Okay, now let's talk a little bit about OCU 400.
Yeah. So OCU 400 is subretinally delivered, trip to the operating room, vitrectomy, subretinal injection. So that's one way to differentiate. It is AAV5 based, and it's delivering the NR2E3 gene. And this is actually to target broadly for all patients with retinitis pigmentosa, despite no matter their mutation. And the reason that it does that is because what this NR2E3 gene does, it's a nuclear hormone receptor modifier gene that's critical for retinal cell homeostasis, for metabolism, and it aims to enhance the photoreceptor and RPE survival and function, and either preserve or restore vision in patients with genetically diverse forms of RP. So just to, again, differentiate, this is not gene specific. So in a open label trial that has been done, a multi-center phase 1/2 trial involving 18 RP subjects, OCU 400 demonstrated safety and tolerability. The treated eyes showed stabilization or improvement in exploratory efficacy endpoints, including the multi-luminance mobility test, which is a maze. The patients are walking through a low luminance visual acuity, or LLVA, BCVA, and this was at 12 months post-dosing. The treated eyes showed an approximately 10-second statistically significant improvement, speed increase in their ability to complete that maze. And then a 75%, which was 6 out of 8 treated eyes in the phase 3 eligible subgroup, showed visual function improvements versus the untreated eyes. And at 2 years, the treated eyes across multiple genotypes, including rhodopsin, demonstrated statistically significant improvements in visual function compared to their untreated eyes. So OCU 400 is currently being evaluated in a phase 3 trial. It's enrolling patients with confirmed clinical phenotype of RP. It does include rhodopsin as a cohort, but it also has a larger cohort of other RP associated genotypes. Again, it doesn't matter what the genotype is. So it's a multi-center study. 150 patients is the goal, with early to late stage RP, and again, in a gene agnostic manner. So that's just a different program. And again, it's subretinal.
Wow. Pretty exciting here. It seems like already in phase 3. So much going on. That's why it's great to have you here, Christine. It's different targets, different mode of delivery, different MOAs and whatnot. Okay, so we covered some of the program. Let's talk a little bit more. So can you tell us a few updates on other gene therapy programs, let's say for XLRP, LCA, and XLRS?
I'll talk about 4 different products. So at AGTC 501, which we're going to talk about X-linked RP, OPX LCA5, so we're going to talk about LCA5, and ATSN 101, which is another LCA, and then ATSN 201, which is X-linked retinoschisis. So number 1 is this, it's called Laruzova, or AGTC 501, which is a gene therapy currently investigated for RPGR X-linked RP. X-linked RP is a very aggressive disease that we see in our young males, 8 to 10-year-olds, family history, aggressive loss of vision. They're often blind, legally blind in their 30s, lost their driver's license in their 20s. They may never get a driver's license because of their visual field. Very aggressive disease. We think that the RPGR gene probably affects the mutation 1 in 25,000 males in the U.S., Europe, and Australia. So pretty common and a well-known entity form of X-linked, form of RP. And again, it's just extremely severe, very aggressive. I hate having to give this diagnosis to families. So the AGTC 501 is a gene therapy that delivers the RPGR gene, the ORF15 gene, to produce a full-length protein. 2 studies I'll mention. DAWN is an open label study of this Laruzova in the fellow eye of male patients with X-linked RP who had been previously treated with an AAV-based gene therapy. The study was looking at 2 different dose levels for efficacy, safety, and tolerability. And interim safety and efficacy results from the phase 2 DAWN trial demonstrated it was well tolerated by all the participants, and showed some promising improvements in visual function across several key measures. Currently, their pivotal phase 2/3 VISTA trial for patients with X-linked RP has completed enrollment. VISTA is a phase 2/3 randomized controlled masked multi-center pivotal trial evaluating the efficacy and the safety, of course, of Laruzova in 2 study groups compared to untreated control. So they have a control group in this. The study evaluated the proportion of participants with a 15 or more letter increase from baseline. Low luminance visual acuity was chosen as the primary endpoint, and additional measures of functional vision. So very exciting. And
lots of phase 3s going on in IRD.
Lots of phase 3s. So we're going to talk a lot about some potential exciting data here. So number 2, OPX LCA5 is a gene therapy targeting LCA type 5, which is admittedly a rare form of an IRD. LCAs in general are rare, and LCA5 is one of these, but it's a devastating form of visual visual loss and retinal dysfunction. This therapy uses an AAV8 vector, and it's delivering a functional LCA5 gene to the outer retina. It's using the same chicken beta active promoter that was used in Voretigene and Parvovac, just for interest. A phase 1/2 study of this OPX LCA5 is ongoing, and they have released 12-month data available from 3 adult patients in the low-dose cohort, which was a 1E10 vector genome per eye. Each patient had severe LCA5, again, very severe visual devastating disease, but with limited but detectable photoreceptors and disease progression to the central retina. So the data at 12 months, all the treated patients identified more objects compared to baseline on this multi-luminance orientation mobility test. This was a virtual maze, which is becoming more and more something that we're looking at in the IRD world rather than the walking around a huge room maze that was previously done with the Voretigene and Parvovac. These virtual mazes are becoming more widely used, and that's what this maze was. Number 2, there was a 3.5 line improvement in visual acuity across the 3 patients at 12 months. Next endpoint was full field stimulus testing, or FST, which is a very powerful endpoint in inherited retinal disease trials. It demonstrated larger improvements in sensitivity from baseline with a 0.86 log improvement, which is huge, at 12 months versus a 0.16 log unit for the control eye. So a significant increase in FST. Microperimetry was only evaluable in 1 subject. You have to have fixation to be able to perform microperimetry. However, at 12 months, the fixation stabilized and shifted towards the foveal center in the other 2 participants, and there was improved central fixation. Regarding safety, this was well tolerated with no reports of DLTs or serious adverse events. And 3 pediatric patients have also been treated for this, again, for LCA5. Wow. All right, moving into number 3, we're going to talk a little bit about another form of LCA, another severe form of LCA, LCA type 1. And so this is caused by biallelic, meaning 2 mutations in the Gucci 2D disease. In the study that was completed, a dose escalation phase part A, 3 cohorts of 3 adult patients, each were treated with 3 ascending doses of ATSN-101. In the dose expansion, an additional adult cohort and pediatric cohort, including 3 patients, were treated at the high dose from part A. All the adverse events were grade 1 to 2 in severity, and majority were surgical related. There were no serious adverse events. For patients who received the high dose of ATSN-101, the mean change in dark adapted full field stimulus testing, you've heard me mention this a few times today, FST, very important metric for inherited retinal disease trials. You don't have to be able to fixate to do FST, was a 20.3 decibel improvement in treated eyes. And that represents an 100, for those of us who don't think in FST and decibels, that's an 100-fold improvement compared to 1 decibel in the untreated eyes. In 2 of the 9 eyes treated at the high dose, improvements in the FST exceeded 40 decibels, which is 10,000-fold improvement. Wow. Modest improvements in BCVA, approximately 8 letters, were also observed. And 3 of the 6 high-dose patients who performed the multi-luminance mobility test, again, what was previously used with Retigene and Parvovec, achieved the maximum score at 12 months. And it's currently planning for a phase 3. The last one, number 4, is called ATSN-201, which is a gene therapy targeting X-linked retinoschisis, another X-linked disease. Aggressive form of vision loss in males, tends to affect the central retina, central vision loss, atrophy over time as the patients age, and peripheral schisis, which can lead to retinal detachments. ATSN-201 is evaluating AAV-SPR, which is a novel spreading AAV capsid that has the ability to spread past the margin of the bleb, which allows treatment outside of the fovea. So the treated area could avoid the fovea, yet the fovea could still be transduced, which is very helpful in X-linked retinoschisis when the retina is very fragile. And we know for X-linked retinoschisis, we need to treat directly those photoreceptors because that's where that RS1 protein needs to be expressed. So part A of the study evaluated safety and tolerability of 3 doses administered to 1 eye, subretinal injection, 3 cohorts of three adults. ARVO 2025 was presented. ATS1 has been well tolerated in all 9 patients, no reported serious adverse events. There were preliminary evidence of efficacy in all 3 dose levels. 7 of the 9 treated eyes had closure of their foveal schisis. So that's a very important structural endpoint in X-linked retinoschisis. If those of you who haven't seen an OCT, it's pathognomonic, so big schisis cavities in these X-linked retinoschisis. 7 of 9 treated patients had closure. The 2 that did not show closure had blebs that were slightly off-center in treatment, slightly peripheral, and 1 had an epiretinal membrane that developed due to laser during the case. In contrast, 0 of the untreated eyes had closure of foveal schisis. Improvements in visual function were generally observed in the eyes with the structural schisis closure. On microperimetry, 6 of the 9 patients had improvements by greater than 7 decibels in 5 or more loci, which is the FDA guidelines for microperimetry improvements. And statistically significant improvements in BCVA and LLVA were also reported. So enrollment in Part B of that study is currently ongoing and will evaluate 9 additional adults and 3 pediatric patients with X-linked retinoschisis.
So, Christine, that was great overview of so many exciting programs that are happening. I think as a leader in this space, I think it's great to hear from you so that our audience can kind of see so much excitement is happening, and especially late-stage programs, as you mentioned. So now let's move on to Stargardt disease before we close this podcast. You know, ALK-001 or glideretinol is very exciting. It's an oral treatment that's being studied for Stargardt disease. Can you tell us a little bit about this treatment and the available data to date?
Sure. So it's ALK-001 or glideretinol, as you mentioned, and it is being studied for Stargardt disease. It is a molecular entity designed to reduce the dimerization of vitamin A without modifying or interfering with the visual cycle. So that's one important differentiating feature of this therapy. We know in Stargardt disease that the ABCA4 gene defect causes increased dimerization, lipofuscin, that's the yellow flecks that we see in our patients with Stargardt. That's toxic to the photoreceptors and the RPE. This therapy allows the visual cycle to still occur normally, so they don't have dark adaptation delay and nyctalopia or other issues, but it reduces significantly the ability for that vitamin A molecule to dimerize and thus reduces lipofuscin. So the Retinal has received breakthrough therapy, fast track, orphan drug, and rare pediatric disease designations. So kind of every designation you get for Stargardt disease from the FDA. And multiple T studies, and this gets confusing because multiple T studies have been done. So I'm going to talk really quickly about, there's 1, 2, 3, 4 that I'm going to mention. They were 4 independent clinical studies looking at this drug, oral drug, like you said, once a day drug in patients with Stargardt. And TEAS1 was the first, obviously, a randomized double mass placebo-controlled 50 patients with advanced Stargardt that actually had atrophy that was measurable. The study is complete. There was up to a 30% reduction in the rate of growth of atrophy. FAF, atrophy is how we're measuring this, versus the untreated patients. TEAS2 trial was a randomized double-masked placebo-controlled trial in 80 patients with moderate Stargardt disease, and that data will be presented imminently. So I won't tell you exactly when, but go to the next few conferences. TEAS3, a clinical trial in early stage Stargardt disease, is an ongoing open label study of Retinal in genetically confirmed individuals with early signs of disease that are visible on retinal imaging, but who have not begun to have symptoms of vision loss. So TEAS3, think very, very early disease. And this is the study that, you I think specifically asked about. And yes, there are 5 patients who have completed 2 years of treatment in TEAS3. Stabilization of BCVA, of best corrected visual acuity, was noted. And importantly, there was less loss of the ellipsoid zone area compared to historical siblings. This was recently presented earlier this year at ASRS and then at Retina Society. So the ellipsoid zone area, less loss compared to siblings. And TEAS4 is an open label extension study. And importantly, just to mention safety, I think I forgot to mention safety, excellent safety profile. Most AEs were mild or moderate. And again, no complaints of dark adaptation delay or visual cycle related complaints.
Wow. Very exciting, oral drug for Stargardt showing benefits. So yeah, I can't wait to see more data on this program and hopefully regulatory approval in the next few years if the data is positive. So Christine, so much to cover and you summarize all the excitement that's going on. Now let's come back to you. I mean, you have done so much work at such a young age and you're involved with essentially everything in the space of IRDs. So tell us, what career achievement are you most proud of to date?
Well, thank you for telling me I'm young. I feel like I'm not as young. I'm celebrating my 20-year med school reunion, University of Florida, Go Gators, in a week. I
love it.
I have my friends from med school flying in to visit at my house and my farm, meet some goats. So yeah, I'd say I'm kind of mid-career, definitely not early. And I'm proud of the IRD practice that I've kind of built, and it's been a passion and a love. I think you've noticed that I'm very passionate about what I do with inherited retinal disease.
Yes.
And I'm passionate about clinical trials, as you are the king of clinical trials. I think it's been fun watching you and this, watching you develop an incredibly busy clinical trial practice and be a leader in clinical trials. So that's also, it's been an interest of mine of developing in a private practice setting a clinical trial research practice. And I think that that's been fun and it's been challenging and I enjoy it and continues to grow. We get busier and busier. So a lot of trials underway.
There's so much to do. And I'm always, as I said earlier, inspired by your energy and your passion, which is always infectious. So I call you young because I already celebrated my 20th med school graduation anniversary. So you're right. Like, we are considered mid-career. We're not young for sure, but we have a long way to go. And I think, we continue to work hard to bring new treatments for patients. So I know you're very young still, and you have another 20, 30, 40 years to practice. But tell us, how do you like to be remembered when you retire?
Wow. When I retire, Yeah, that's a good question. Well, I'd hope that my patients and my staff and colleagues, we all love our retina conferences and all of our colleagues you see. I hope I'm remembered, as a good doctor, a researcher, an innovative person, and just most importantly, a kind and caring individual that cares about their patients. I think that, my particular kind of soapbox and things I sort of always hear myself say to patients or when I'm at various conferences is I want to be the doctor that's remembered for saying to patients, it's not okay to tell a patient that there's nothing that we can do for you. I think there's always something that we can do for patients. And I tend to see a lot of late stage disease, a lot of, severe vision loss, a lot of inherited retinal disease, and that can be depressing conversations. But I like to be a hope and optimism doctor, and I like to be able to offer patients realistic hope and optimism, not just, ideas. But I think that pushes me to continue to work in the research field, working with companies, helping develop pipelines in the preclinical data, and then watching that play out in clinical trials and being active in the clinical trial world. And so I think being able to offer new treatments and cures potentially for patients that otherwise have no hope. That's my goal, is to be able to continue to offer hope to patients and be remembered for being passionate about what I do.
Definitely. I think you're already there. And when I think of you, I think of high energy, passionate, hopeful, and a fighter for patients. So thank you, Christine, for excellent discussion and teaching me and our audience about the latest and greatest happenings in the IRD world. I also want to thank our audience for listening, and thank you, Christine, again.
Well, thank you for inviting me. This is always wonderful to get to do anything with you. I enjoy working with you. You're great. So appreciate it. Thanks for having me today.
It's a pleasure, Christine. Thank you. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.